Welcome to the USMLE question and answer blitz. We are diving into a high yield questions. Remember, in the exam, you get 90 seconds per question in a 60-minute block covering 40 USMLE questions. Get your coffee. Let's nail this case and keep rocking our 40 question block. Alright, so here is your question. We have a 62-year-old man with hyperlipidemia who presents with progressive proximal muscle weakness and myalgias for 3 weeks. He finds it hard to climb stairs and rise from a chair. He has been on high dose of atorvastatin for 6 months. Lab shows a markedly elevated creatine kinase at 2400 units per liter, and muscle biopsy demonstrate muscle fibers necrosis with minimal inflammation. The question asks, what is the primary mechanism behind this patient's condition? And here are your options. And the correct answer is depletion of coenzyme Q10 with impaired cellular energy production. Statin inhibits HMG-CoA reductase, blocking the mevalonate pathway. While this effectively lowers cholesterol, it also decreases synthesis of coenzyme Q10 or ubiquinone. CoQ10 is critical for the electron transport chain in mitochondria, and its depletion leads to reduced ATP generation in skeletal muscles. This explains the patient's weakness, muscle pain, and elevated CK levels. Now, let's rule out the other options. Inhibitions of mitochondrial DNA polymerase gamma is the mechanism of nucleoside reverse transcriptase inhibitors. Ubiquitin, a proteasome pathway activation occurs in muscle wasting conditions such as cachexia, not with statins. Sodium channel dysfunction is seen in periodic paralysis syndrome, while free radical damages can cause toxic myopathies, but it's not the mechanism of statin myopathy. So the best explanation is coenzyme Q10 depletion and impaired energy production. And here is your learning objective. The key takeaway, statin-induced myopathy is due to reduced CoQ10 synthesis, which disrupts mitochondrial ATP production and leads to muscle fiber necrosis. Clinically, patient presents with myalgias, proximal weakness, and elevated CK. Risk is higher with high-dose statins, advanced age, and drug interactions. Management involves discontinuing the statin and, if needed, switching to lower dose or alternative lipid-lowering therapy. So remember, statins plus muscle pain plus high CK equals think about CoQ10 depletion. So here you go, folks. We'll see you in the next question. Stay tuned.